We're on to chapter 29, chest injuries. Chest trauma causes a significant amount of ER department visits. It's estimated more than 700,000 each year, and approximately 18,000 deaths are attributed to chest trauma itself. Um, a lot of this is going to be because there are so many structures within the thoracic cavity, such as the heart, lungs, and then a lot of blood vessels, that there's just a lot of things to break in there. And truthfully, blunt trauma, penetrating trauma, having a combination of both, it really doesn't matter. That region is just susceptible to massive injury. So we have to treat any injuries that interfere with normal breathing and function. Um, but this can be more than just treating that specific injury, but preventing air from collecting in the chest, which will then prevent lung expansion. So if we've got an open chest wound, we have to make sure that we cover that so that no air can continue to come in through that hole. You can have a lot of internal bleeding because of the massive vessels in the heart that's contained with air. And so that can compress the lungs and heart as well. So a lot of these things are going to be something that we can't truly take care of in the field. We can put Band-Aids on, such as calling ALS to do a needle chest decompression, but it's not going to fix the problem. They need to be transported in. So going back to A and P, there is definitely a difference between ventilation and oxygenation. Ventilation is just that mechanical process of getting air into and out of the lungs. Oxygenation is actually delivering oxygen into the blood at the alveoli and then out into the tissues of the body. Your thoracic cavity or your chest extends from the bottom portion of the neck all the way down to the diaphragm. And here's a picture of that as well. But if you have a penetrating injury to the lung, that diaphragm isn't super thick. And so you do have the possibility of abdominal injuries as well as chest injuries, kind of depending on how that moves around. Your chest area does have some unique features. So you have striated muscle, which is typically for skeletal, but you do have some of that there that allows for adequate ventilation. So you have those intercostal muscles in between the ribs that help elevate the chest so that you have more of a negative space created. Patients that don't have those muscles developed end up doing what's called belly breathing. So little kids use a lot of abdominal muscle strength in order to breathe. Your diaphragm, as well as those, your diaphragm is actually a cranial nerve, but you have some skeletal muscle control or spinal nerve control in that area as well. You have tons of bundle branches there. You have a neurovascular bundle, which lies right along the lowest margin of each rib. And you can easily injure these. So rib fractures significantly hurt, like more than some other fractured bones, because they do have a massive bundle that's running right along them. You also have vasculature that runs the same course. That's why it's called a bundle. And rupturing one of those can lead to some pretty significant bleeding as well. Your pleura, you've got that lining that covers not only both lungs, but also the lining of the thoracic cavity. You've got your parietal pleura, which is that inner chest wall lining. And then the visceral pleura actually covers the lung itself. There's a little bit of fluid in between the two in order to prevent friction, just like there is on the heart. Your ribs are connected to the sternum in the front, mostly by costal cartilage, and then directly into the different vertebrae in the back. You also have your trachea, They're within an area called the mediastinum, which also has the heart, the esophagus, and the other great vessels. And then you have that diaphragm, which is basically the dividing line between the thoracic and abdominal cavity. And at any given time, it's at a different point. So relaxed, it's clear up under your rib cage. When you inhale, it actually drops down closer into the abdominal cavity. So you never can quite perfectly pinpoint where it's at. Your mechanics of ventilation we have gone over, but your intercostal muscles, those between your ribs, contract, your diaphragm contracts and actually drops down. And then that causes a massive negative pressure within your lungs, particularly, and air rushes in. And then when all of those things relax, you have a bunch of positive pressure, and the air goes to the area of least resistance. And so it ends up going out into the ambient air around you. Here's kind of the overall look of how things are. The diaphragm being contracted in that left side. You can see how the liver and the intestines end up moving down to accommodate that change. You've got the inflated lung. There's a lot of space in there. And then once that diaphragm ends up relaxing, it comes up. Your liver is going to come up as well as the intestines, and you're not going to have a lot of air within those lungs. Sorry. There we go. Patients with a spinal injury below C5, so the bottom portion of the cervical spine, can still breathe from the diaphragm because remember that comes up very, very high in the neck. Patients with a spinal injury above C3 may end up losing the ability to breathe. The patient below the C5 level still has the power to utilize those intercostal muscles more, and the diaphragm should still contract because that phrenic nerve remains intact. Measuring some different volumes, which we have talked about, but minute ventilation or minute volume is really what we're going to focus on. That's the amount of air that's moved through the lungs in 1 minute. You end up calculating your normal tidal volume by your respiratory rate, so the amount of air that you take in by how many breaths per minute that you have. A patient with decreased tidal volume, they're going to naturally compensate by increasing the respiratory rate. Typically, our bags or BVMs are much higher than what a patient's going to take in for a normal tidal volume. And we don't want to overinflate. So when we're actually ventilating a patient, we're going to ventilate to the point of chest rise and then stop. Bags on average are about 1,200 milliliters. And really, we only need about 5 to 6 in order to adequately ventilate the patient, about half of that bag. We certainly don't want to do that. Injuries to the chest, we've got 2 types. We've got open and we've got closed. I think they pretty much speak for themselves. Closed chest injuries, the skin is not fully broken. You have that generally being caused by blunt trauma. Even though this may seem like it's not as bad, you can have a lot of significant injury beneath that skin that you're not going to see. The heart can be damaged and it may not be able to refill fully with blood, or blood might not be able to be pumped with enough force out of the heart. You can have lung contusions, which is bruising in the lung, but that little bit of collection of blood makes it so that you can't exchange across that alveolar membrane. So where the air actually comes into your lungs, it goes down to the little bundled alveoli and then transfers across a very thin membrane. If you have interruption in that because of fluid, be it blood or swelling, any sort of edema, that air can't exchange there. It's not going to be able to diffuse through the liquid to get to the membrane. It just doesn't happen. So that can cause significant issues. Rib fractures can cause even further damage. It can end up acting like a knife in there. Every time you breathe, those broken ends are going to move, and they're going to cause further damage to the skin, to the nerves, and then to the vessels that lay underneath of them as well. Closed chest injuries are different than those open. Open, obviously, you have an object that penetrates through the chest wall itself, but you can have both simultaneously. So often this is going to be a knife, bullet, piece of metal, broken end of a fractured rib, anything that can go through the body. And if you put enough force on most objects, you can get it to go through the body, unfortunately. So if you have an impaled object, we're going to leave it in place. It may be actually occluding the whole of a punctured vessel. And if you pull that out, all of a sudden now we've got massive bleeding that we can't control because we can't get inside of the chest cavity itself. And then all of the damage that you could get from it coming out, just if you can splint it in place, definitely a better option. Blunt trauma can cause issues with the rib, the sternum, and then the chest wall as well, mainly the ribs. You can have bruising to the heart, bruising to the lungs. You can have vital organs to be torn from their attachment points. Almost 1/3 of people that are killed immediately in a car crash die because there's a traumatic rupture of the aorta. So the largest blood vessel that comes out of the top of your heart, if you take enough force, that thing can actually tear open. And there's not a whole lot anybody can do for you there. Signs and symptoms: pain at the site of the injury, irritation every time you breathe, makes that pain worse. Bruising to the chest wall, crepitus, that's kind of if you were to grab like a bag of Rice Krispies and move it around in your hand, that kind of sound. I know that was fantastic. Probably didn't do anything for imitating the true sound, but that is what those bone ends rubbing on each other, it sounds like Rice Krispies. You can look for any opening in the chest. Shortness of breath can be caused by several different things: airway obstruction, damage to the chest wall, improper chest expansion, or compression of the lung tissues. You can have hemoptysis, which is spitting or coughing up of blood, which obviously indicates damage to the internal surface of the lung, that there's blood now getting in there. You can see that there is a failure of one or both sides of the chest to normally expand. So not only should you see the chest expanding, but it should expand symmetrically. You can have a rapid, weak pulse and low blood pressure. Those are principal signs of hypovolemic shock. And this can be because of massive bleeding within the chest cavity. And then cyanosis around the lips or fingernails because the patient is having inadequate respiration, so now they're not perfusing adequately. Oftentimes patients with chest injuries will have tachypnea, but they'll also breathe really shallow because blatantly it hurts to take a deep breath. And so they're naturally not going to breathe the way that they should. You want to auscultate multiple locations on the chest and on the back to make sure that there's adequate breath sounds everywhere, because that may be a complete different issue. But make sure that you're definitely taking a good listen to somebody that has a chest injury so you can try and determine what the cause of their shortness of breath is. We'll stop here and continue on in the next.